Welcome. I'm Patty Smith with the Healthy Shelby Community Partnership in Memphis. We're pleased to present the first part of our three-part webinar on advanced care planning conversations. In the first segment, you will learn about why these conversations are so important to your patients. Our presenter is Jerry Ashley, Assistant Director for Life Planning and Palliative Medicine Services at Baptist Memorial Healthcare Corporation in Memphis. Jerry is an advanced practice nurse certified in oncology, hospice, and palliative care. She has 40 years' experience in nursing, nursing administration, and training healthcare providers. Jerry, let's get started.
Good morning, everyone. It's very nice to be here, and I'm glad you've joined us today. In this first section of the webinar, we're going to look at the important conversations that patients need to have. It's important not only for the patient, but it's also important for healthcare providers. The first topic will be on why conversations matter. So we're going to examine some statistics, why this topic is so important. 90% of people report that talking to their loved ones about future healthcare decisions is important. However, only 27% of them actually have done so. These discussions can be difficult, and they can't cover decisions about every medical treatment or technology that may be available at the time the serious illness occurs or progresses. So the conversation consists of having a shared understanding between the physician and the patient of the quality of life one values, and the discussion of those qualities that give their life meaning. For example, being able to communicate with their loved ones. 80% of people say that if they're seriously ill, they would want to talk to their doctor about planning for future health care. But sadly, only 7% of patients report that they've ever had this conversation. In a study of the role of the physician in advanced care planning, it revealed that greater than 60% of those interviewed believed that advanced care planning was an important task for the physician. However, few reported doing so with their patients. 70% of patients say they would prefer to die at home, but 76% die in institution. 50% of those patients die in hospitals, and 25% die in nursing homes or long-term care facilities. Early advanced care planning discussions, both for the family members and the physicians, could make a drastic difference in their care and in those statistics just listed. At the time when healthcare decisions are necessary, 50% of patients are unable to make them. And without preparation, families are not equipped to decide. Often, family members are chosen by the patient without knowledge of being appointed as a decision maker or a healthcare agent by the patient. When called upon to respond to physicians and healthcare providers' questions, the family members are not prepared to answer them. And when pushed, they will unreliably predict patient choices. Regardless of whether family members choose aggressive therapy or comfort, the evidence shows that family members suffer from stressful flashbacks to those days when decisions were made, and that those flashbacks will go on for years. They are left at the time of the patient's death, still unsure whether they did the right thing. Lastly, if healthcare members are uncertain about what the patient wants, they will err on the side of life. So patients may get care they do not desire. This slide reports the patient priorities for care during serious illness. It's clear that they want good pain and symptom management. They do not want their dying prolonged. Rather, they want quality living prolonged. They want information, and they want that information in a way that they can understand it. They want a sense of control. This need is very closely related to the need for information. Healthcare and disease information should be given in a manner that's understood by the patient for them to achieve that greater sense of control. Next, they don't want their families burdened. Yet in the absence of an advanced care planning discussion, the family does not always know their wishes. Conversations really do matter to get across to the family members what the patient wants. It requires a conversation, sometimes multiple conversations. The patient wants their family relationships strengthened, both between the patient and the family members and among the family members. That can occur during these conversations as one sort of gets into the nitty-gritty of discussing life and death situations and the values that matter deeply to the patient. Advanced care planning allows patients to have less depression, and it is believed that this is related to the fact that they face death, have control due to having a health care plan, and because their families are prepared. They believe that their doctors understand their wishes from their advanced care plan, and further, that the doctor understands them better as a person and actually cares for them more. I've even heard patients say, "My doctor thinks I'm special. He really understands what I want." For the doctors to understand what is in that advanced care plan represents to the patient his knowledge of their personal values, not just their disease condition. The patients are better prepared for death. They've actually looked at death in the face, have examined it and their beliefs in death as well as the quality of living, and in doing so are less afraid. Caregivers, when informed, are able to advocate for the patient and report fewer burdens and even calmness during their grief trajectory related to the knowledge that they have done the right thing for the deceased loved one. They know they did the right thing. They're sad that their loved one's gone, but when they realize they've done the right thing, they know they have given the patient the gift of following their wishes, and the patient has also given the family member a gift by informing them of their values. So why don't we plan ahead? These 4 graphs, which we'll go through individually, help us understand the reason why we don't plan ahead. So first of all, to lay the groundwork, if you ask 100 people in the United States, how would you like to die? The vast majority of them would say they want to die in their sleep. This is what's reflected in this graph. They want to die suddenly, without suffering, without pain, without symptoms. So this slide shows the trajectory in a graphic presentation, the vertical axis showing function and the horizontal axis showing time, although no specific time frames are noted. The only place where advanced care planning really has a role in this trajectory is for the disposition of the remains and possibly funeral plans. However, the point of this slide is that only 10% of patients will die that way. 90% of us will die in one of these other 3 ways. Patients have a very high level of functioning during diagnosis and treatment of cancer, often working and busy with family and other activities. They continue to do things they enjoy, and they're able to manage their symptoms during treatment. But at some point, the patient hits this slippery slope and they will progress toward their death. Cancer patients do not plan their health care ahead because they are functioning at a high level and they are reaching and striving for a cure. However, at the time of the slippery slope, they are not always decisional. Therefore, no advanced care plan is implemented. And prognostication is not accurate. In a study which included physicians from 35 different specialties, the accuracy rate was only 17%. The purpose of planning ahead is to get ready before that time that these decisions are needed. Having those conversations early really does matter. This slide represents a graphic demonstration of dementia and frailty. So as you can see, the patient is diagnosed often at a very low functioning level, and the patient sort of dwindles toward their death. Anywhere along that line, the patient can lose the ability to make decisions. Advanced care planning is needed early before they've gone into that deep forgetfulness or that debility of frailty. Early conversations with family and the patients do make a difference in decisions later. Now, organ failure. This trajectory is marked by a steady decline, but also punctuated by periods of illness where hospitalization is often required. For the patient, they have always recovered well, but at some point, that trajectory dips and does not go back to the baseline, and they don't recover. It's often difficult for the healthcare provider to know when that dip will be the final one. So for both the patient, the patient's family, and the physician, planning ahead is important so that decisions are made in accordance with the patient's wishes. So how can healthcare providers help patients plan? We'll examine two important parts of the advanced care plan. One is having a written plan called an advance directive. Second is deciding on the decision maker. Let's look first at the decision maker. Choosing the decision maker is important, and to do it early is the best plan. Patients need to be encouraged to figure out what their desires are for health care. What do they value about their life? What gives their life quality? What is that line in the sand where the patient would put their foot down and declare, "This is enough treatment. I wish to live the remainder of my life in comfort, with my symptoms managed and doing those things I need to finish before death comes"? What are those things that a patient is not willing to forfeit and that a healthcare decision planned ahead might prevent from happening? For example, if cognition were important to me and that was going to be impacted either by my condition or by designated healthcare treatment, the question becomes, would I want my life artificially prolonged if that were inhibited? The defining qualities of life vary from patient to patient, and they're dependent on a lot of different life factors. When picking the decision maker, the patient needs to pick someone who's aware of those values. They need to know what kind of leeway they have for making decisions, because not everything can be planned perfectly and easily decided during times of healthcare crisis. Second of all, the decision maker needs to have a copy of the written directive, which we'll discuss in a moment. Thirdly, the decision maker needs to be someone who can stand in the gap in a time of crisis decision making and respond as an advocate for the patient's desires. Often these decisions are requested at the doors of the ICU, and it's a stressful time. Patients really have to prepare their decision maker as best they can for what kind of care they wish to have. You will notice on the slide that we've listed the different states. The decision maker is called by different names depending on which state the family initiates the advanced care plan. The last point I will make about the decision maker is that it is the patient who empowers the decision maker. It is not the healthcare provider. The patient appoints his or her decision maker or decision makers. The second important part of an advanced care plan is the one that's written. The first example we show here are the state forms. They're primarily focused on medical decisions, but they're again based on what the patient values for their life. This may be something you introduce the patients to and ask them to give some serious thought to those options, and then have them come back at a separate point to have a discussion about them. What they need to focus on is the quality of life they desire during serious illness. Once the patient knows the quality of life they desire, the physician then can guide them in completing this document in how the medical decisions will enhance or remove those qualities. Once the written plan is completed, be sure to get a copy for that medical record. Patients may also tell you they have a copy of an advance directive. When they bring that in, I would encourage you to look clearly at that document to make sure that it is a proper healthcare document and not one that looks at finances. The next option is the 5 wishes. This is the number one living will used in our country today. It's very patient-friendly. It's printed in 28 different languages, and on those documents, each page of the document is printed with 2 columns. On the left is the language such as Chinese, and on the right it is printed in English. 5 Wishes is approved for use in 42 states, costs $5 or less depending on how many copies are ordered and purchased. It can also be done online for the same $5 price on the Aging with Dignity website. Patient has 30 days to complete it when using the online model. Once the online document's completed, the patient can print it off, sign it with 2 witnesses present, and it will be ready to distribute to family members and healthcare providers. Although not required in Tennessee, Mississippi, or Arkansas, an attorney can also be used to do a living will as well as financial wills and estate planning. This slide shows examples of specific forms such as the Spanish form and the Catholic form. To learn more, here are a list of a few patient-friendly sites where the patient can go for assistance in thinking through and completing their advanced care plan. The Prepare for Your Care site actually reviews the steps of preparing and completing a plan. It uses videos to aid in that process and has both English and Spanish options. Second, the American Bar Association helps patients decide on a decision maker when they cannot speak for themselves. Lastly, the Pew Research Center has information on how religious beliefs impact our medical decisions. To close this section, I would like to mention a special thanks to the 4 groups that are working together in a community collaborative here in Tennessee and are supportive of this webinar today. I hope you'll stay tuned for the remaining sections of the webinar focused on advanced care planning discussions and capturing reimbursement. Thank you.